Good afternoon, everyone, and welcome to the very first session of the WiROSE Lunch and Learn series for Wisconsin Coalition members. My name is Liz Dorsey, and I am project managing some of the WiROSE project, and Megan, who was supposed to be doing this introduction, is the program manager for Program for Research, Outreach, Therapeutics, and Education in the Addictions. We're really excited to have you all joining us here today. The Lunch and Learn series is part of the Wisconsin Rural Opioid and Stimulant Engagement Project, which focuses on addressing prevention, intervention, and recovery of opioid and stimulant use disorders in rural communities. And it's funded through the Rural Opioid and Stimulant Engagement Grant from SAMHSA. So this series will have a session every other month. This is our first one, and each session will provide an opportunity for experts and community members to share their experiences and insights on substance use issues in their community. The sessions will also provide a space for discussion, we're hoping, so that community members can connect with others and hear about what other coalitions are doing across the state in this subject area. If you were unable to register via the Zoom invitation previously sent, please private message Megan your name, email, organization, and coalition affiliation. I'll throw that info into the chat. Today's session will feature Dr. Randy Brown, and he will present a background and short history of addiction. And I think with that, I will turn it over to Dr. Randy Brown so he can introduce himself and start his presentation.
Thanks a lot, Liz. And thanks for the effort there, Megan. We'll get that teed up for next time. Well, welcome everyone. I'm Randy Brown, and I'm in the Department of Family Medicine and Community Health at UW. Been here about 20 years now, and my original training is in family medicine, but then gained additional certification in addiction medicine. And my work has really been focused on, and I've really been driven by sort of systems outside of specialist treatment to improve sort of care delivered and services available to people who use alcohol and other substances in ways that might put them at risk. And so, as part of our first session of the Learning Community series, I thought, I'd start off with just a very high level view around substance use and addiction, what it is and the foundations, and how we tend to approach how we might think about treatment. Again, with kind of an eye to, what do we do when resources may be a challenge for folks to get to, which is true in many communities and for many individuals, rural residents and otherwise. So with that, I need someone to give me permission to share my screen. I am not yet cool enough. Am I now cool enough? Okay. All right. So now what's going to happen is it's going to put this on a screen where I'm sort of looking away from you probably from time to time. But I'll do my best to reconnect over here. So, being interested in substance use, I think there are a lot of layers to it, and a lot of layers up to addiction, but including other things as well. Megan, can you give me a nod? Are you seeing the full slide view on the screen? Thanks. Because substance use and sort of alteration of the consciousness is something that is a part of life in many aspects or in many forms other than substance use, and it's a fairly primal drive for humans and for other species to seek altered states of consciousness, and that can take a variety of forms. Meditative practices, extreme physical exertion, and a number of other activities that can achieve that. And it's been characterized by ethnobotanists and anthropologists as quite a primal drive, akin to the drive to eat when we're hungry or drink when we're thirsty, and motivation to sexual behavior and shelter and things along those lines. And so it's deeply very much a part of what it is to be a human, among other things, including other species that also routinely seek out altered states of consciousness and routinely seek it out through mind-altering substances, actually. And there are just a few examples here. This is most commonly sought out, and not just happened upon, but as I've indicated, actually sought out, these alterations of consciousness, most commonly through fermented fruits and things like that, and the intoxication that comes with the alcohol produced. And it's thought to confer a survival advantage in some way, that these alterations of consciousness and perception may confer some advantage in terms of new approaches to problem solving and things along those lines. But addiction in lower species, air quotes, is quite unusual. Some interesting things, though, that are somewhat analogous to this in humans is stigma being attached to it. And sort of one of the most interesting examples to me is actually the honeybee that you see here, where if a member returns to the hive intoxicated, they get kicked out until they can come back in a more sober frame of mind. But as individuals seek out altered states of consciousness through the use of mind-altering substances, yes, the vast majority of the time, in the majority of those instances, there isn't discernible consequence attached. But in individuals who are vulnerable and use repeatedly, a syndrome known as a use disorder or addiction may develop. And it's quite common. As many of you likely already know, fully 20% of the adult population in the United States will meet criteria for a use disorder at some point in their lives. And that proportion is even higher when we look at individuals in healthcare settings, such as primary care and hospitals. And some of these numbers contain a lot of what drives what I do, in the lens through which I look at this is, this problem is so much more common than so many things that we spend so much more time on in medicine. Through my medical career, I've seen maybe 2 cases of lupus, but it's almost daily that someone in routine practice in healthcare, or even in the course of their daily lives, is going to have contact with someone who's engaging in substance use that may be in a risky pattern that puts them at risk for harm, or that actually are struggling with substance use, which makes it quite tragic that, given the extensive consequences attributable to substances, that the vast majority of individuals who could benefit from treatment aren't receiving it. Further, adding layer to that set of tragedies is the fact that the majority of individuals who are struggling with an actual substance use disorder have contact with some aspect of the system. Here, I demonstrate 2/3 have contact with healthcare, but plenty of other settings in our community with whom they might have contact where, if care were more mainstreamed and approaches more mainstreamed, we might be able to make more of an impact. So what are we talking about when we're talking about addiction? And I put that in air quotes in quotes here, because a lot of the references that we use in healthcare don't really use that term. They use the term use disorder, but it's pretty clearly understood that those are used interchangeably. And so one of the frameworks that's often used to think about or understand addiction and what it is that it's actually an illness or a condition in the brain, that the brain of someone who is addicted is different from the brain of someone who is not, in some ways that are pretty predictable. And what you're seeing here are images indicating the rates of metabolism in a part of the brain known as the mesolimbic system. And that's sort of our primary reward pathway, or the pathway in our brain that motivates us to engage in behaviors that help guarantee our survival. So again, eating when we're hungry, drinking when we're thirsty, and things along those lines. And those activities positively reinforce us to do them again to help us maintain our survival. The thing is, particularly for individuals that are at high risk for it, a number of the substances we'll be talking about actually trigger this pathway and positive reinforcement more intensely than any of those survival guaranteeing behaviors do. That can make them difficult to resist for individuals that are at risk for developing a use disorder. And what you're seeing in this slide on the left is imaging in that system of someone who in this case has not used methamphetamine. In the middle, someone who has used methamphetamine regularly but is only recently abstinent, where you can see from the normal brain that higher rate of metabolism, that red area has been dramatically reduced, almost obliterated. But on the right, you can see with longer periods of abstinence that regeneration does occur. And that correlates with functional recovery, reductions in craving, and reductions in use. So the case is not hopeless, and treatment does work, and remission can be achieved. But as you'll see here, this recovery, this healing takes many months. And so the perhaps antiquated idea that someone could go to a program for 4 weeks, come out of it and be changed and move on is probably not the best way to look at how some of these things should be addressed. And longer term care and monitoring is likely needed. And so I made mention of the term use disorder, and this is what that is in the Diagnostic and Statistical Manual of Mental Disorders, kind of the primary reference for mental health diagnoses. And I won't belabor the point here other than to briefly relay what the definition includes is that someone is engaging in maladaptive use. So maladaptive use again, where it's resulting in repetitive consequences in one or more of these areas, in more than one of these areas over the course of a year. And I draw attention to the first two, tolerance and withdrawal, because there can be a lot of sort of misconception around what those things mean. And it's important to have an understanding of the difference between physical dependence and an actual use disorder. And I think a situation that might illustrate that most clearly would be, say, someone who has a chronically painful condition. They're engaged in a multidisciplinary plan to address it. They're adherent to that plan. A prescription opioid has become part of that plan, and they're taking it as prescribed, as instructed for the indication for which it was prescribed. They're going to develop tolerance to that medication, and if they stop it immediately, they're going to experience withdrawal. But that's an anticipated consequence of that prescribing. And if it's alleviating pain and improving their function, that's not a use disorder. And what we're more looking for are these other indications that an individual, again, is engaging in that maladaptive use, that use is compulsive, they're unable to control it without further intervention. They're sacrificing other activities, things along those lines. And so when we encounter that, how do we think about treatment? Well, again, one of my things is we need to be doing it in many settings, and not just in healthcare, and more specifically, not just in specialist treatment agencies, because we know that the majority of individuals, as I made mention of earlier, who have an addiction or a use disorder aren't getting the care that they need. Most often that's because they don't know that they need it. And so we're in places that are making contact or are likely to have contact with individuals with substance use issues. It's important to simply have it on radar and ask the questions, which we don't always do well, depending on the healthcare setting or other settings where folks may have contact with it. Other issues, which I'm sure you might have anticipated, would be if someone does anticipate that they might need help, there are frequently challenges with access. And that's primarily referring to specialty treatment. I'll be talking a little bit more about strategies outside of that can be helpful, that I think are perhaps more pertinent to a lot of communities in which you work. Another thing that I like to draw attention to, particularly when I'm talking to healthcare providers, is another real barrier for someone struggling with an addiction is if somebody starts asking them about it, there can be this very immediate response like, oh boy, this person's about to ask me to quit now and quit forever. And that idea of abstinence can be very fear-provoking initially. And so thinking about a graded approach to achieving that goal, if we think that is the goal we should be recommending most strongly, or perhaps considering, depending on the severity of the use disorder and the substance that we're talking about, there may be plans involving moderation that can work long-term, or at least can open the door to this conversation, start that positive behavior change, and we can evaluate how that's working and sort out whether that can be the plan or whether abstinence in support of it needs to be where we go next. And behavioral treatment is most frequently thought of as the cornerstone of addressing a use disorder. There may be an exception when we talk about opioid use disorders, but for a lot of them, some form of behavioral assistance with lifestyle modification is helpful. And this can be something as simple as what we call brief intervention in healthcare or other settings where concern is expressed around level of use and shared goals around behavior modification are engaged in over a course of a 10 to 15 minute visit. It can even be, and that's been shown to have impact on alcohol consumption and downstream consequences of that alcohol consumption. One of the models with which I'm sure you're familiar, or forms of which I'm sure you're familiar, peer recovery. And in a lot of our communities, that's what's going to be the most widely available to folks. Peer recovery groups are free, they're widely available. The most widely available ones are going to be the 12-step models, such as AA and NA, that tend to be fairly purely abstinence-based. And so that can be challenging for someone engaging them initially. But something that I always tend to encourage, again, given that they're widely available, they're free, establishment of a relationship with a sponsor can take that up a notch, that we recommend for everyone participating, where they have access to someone virtually 24/7 if they're struggling to process what they're going through and assist them. There are other models of peer support, again, not professionally mediated, but where peers are supporting one another in a path to recovery, called rational recovery models. Like SMART is the most widespread out there, but still not nearly as common as the 12-step models. And there's less sort of emphasis on a spiritual component, particularly Judeo-Christian spiritual component that's fairly prevalent with the 12-step models. So some of the folks with whom we have contact may be more comfortable with that where it's available. And in many communities now, there may be access to a peer support specialist or a peer recovery coach. In Dane County, through Safe Communities, a connection is often made in the emergency department or in the hospital to someone with shared experience that can help them potentially navigate path to recovery, or engage in some counseling that will help them stay as safe and as well as they can if they aren't yet ready to make behavior change otherwise in terms of their frequency of use. And then, of course, there are the more typical traditional specialist settings, being outpatient, or counseling maybe one-to-one, or maybe in group-based models. And then, of course, your 28-day, sometimes shorter, sometimes longer residential programs and correction-based programs. among others. And how do we make decisions about which model might be appropriate for folks? So involves a fair constellation of things, and it isn't all just about the use disorder and how severe it is, because there are a number of components to a person's life that might influence sort of services they might need and the likelihood that they're going to succeed, including other medical conditions. They may require more intensive monitoring in a controlled environment. If they have more complicated mental health conditions, fairly unusual for someone with a use disorder not to have some sort of comorbid mental health challenge that needs to be addressed. Likelihood of relapse and recovery environment, of course, important to consider, and may make us think about residential approaches as opposed to others. If, for example, they're unstably housed or live with a close personal contact partner who's actively using or maybe abusive in one way or another. And the framework here is one of a number. This is from the American Society of Addiction Medicine, and so I just put this up by way of an example, sort of shows some of the components that we think about as we're thinking about an appropriate treatment environment for someone who's seeking it. So far as ferreting out what resources are available, working at UW Hospital, we get patients from all around the state and some beyond, and so I frequently need to tap in to some resources since I can't keep in my brain everything available in our 72 counties or in counties beyond our state's borders. Wisconsin 211, many may be familiar with, is a person-facing resource. So a healthcare provider doesn't call that number to seek help for their patient. The patient can call that themselves, or a family member can call that or access it online themselves to get information about resources available in their area. And they also have information about insurances or payers that those agencies will take. And that's limited to Wisconsin. The Substance Abuse and Mental Health Services Administration also has a treatment locator function that you see on their opening page, samhsa.samhsa.gov, where you can enter a municipality or zip code and get similar information, agencies available, the issues they address, and the insurances that they take. And, the Wisconsin 211 and then the next bullet here, county departments of health services, are going to be a bit more up to date than the SAMHSA resource, since that's federally administered and so isn't exactly what we would call real time. But a reach out to substance abuse services contact at the Department of Health Services at the county level. They're going to have very handy and up-to-date information on what's available in the area, what services they provide, and insurances accepted. For those having contact with healthcare providers or interested in how providers might get more comfortable with addressing these issues, I lead a number of training programs to get providers comfortable with prescribing medications for opioid use disorder as well as alcohol use disorder. And we'll be getting information out to the group on that. We have a monthly what's called ECHO session. It actually, well, we're using WebEx now. We used to do it through Zoom, that brings a group like this together. The one we're doing now with our ECHO focuses more on primary healthcare providers, and we have some experts centrally in addiction medicine, psychiatry, counseling, pharmacy, and the like, where providers from around the state can bring in cases that they're struggling with and talk about patients that they're hoping to help, and the community can provide them some advice about proceeding with that. We also have a phone-in line that we can get interested folks information on, where if a provider is seeing someone in their office and they need advice now, they can give a ring and we can provide them some advice around medical management. So far as that goes, there's a similar point of care phone-in line called the Periscope Project out of Milwaukee that addresses issues fairly particular to substance use during pregnancy. So they have access to specialists in addiction, as well as obstetrics and perinatology and perinatal psychiatry, where providers can get advice about helping patients that are in that situation around pregnancy and use disorder. One other program I just draw attention to is Narcan Direct. Major efforts statewide to make sure that naloxone, the opioid overdose reversing agent, is widely available, and education on recognizing overdose and how to use Narcan is getting out to the lay public and the using community. People don't have to be trained in healthcare to save someone from an opioid overdose, and delivering Narcan or naloxone, particularly with the approved routes now, it comes in a pre-filled nasal spray that's quite easy to administer. And so this Narcan Direct gets folks access to free naloxone, doesn't require a prescription, can be also given through pharmacies that have signed up for the statewide standing order, and we can get more information out to the group if there's interest around getting access to that. Really critical, particularly these days, as you've likely heard with fentanyl and related molecules being in the heroin supply. Fentanyl is a highly potent opioid and is responsible for the major proportion of the huge uptick that we've been seeing over the last 2 years in opioid overdose and death in our area. And so having Narcan out there to save those lives and having people educated around its use is super important. I wanted to also throw out some information related to medications that are sometimes used to help people move toward recovery and maintain recovery. Just because in your contacts, people may talk about these or may have questions about them. And there are a number for alcohol, and current recommendations at the national level, say from NIH and from VA, are anyone struggling with an alcohol use disorder who meets criteria for it should be offered a medication to assist them in their recovery. And we have a few options now that operate through some of these pathways that I've put up here that I'll explain in just a minute around how alcohol works and how these agents may help. So alcohol is a depressant or a calming agent, and it works through this chemical called GABA in our brains. That's our primary sort of calming or inhibitory neurotransmitter or chemical in our brain. So if we have a dose of alcohol, it activates that GABA and the feeling is calming. Glutamate, on the other hand, is the primary central excitatory agent, the fight or flight agent. So when someone's using alcohol heavily every day, all the time, the brain says, well, I don't need to maintain this GABA system that I usually keep going naturally anymore because you're giving me this alcohol. I'm going to downregulate that or suppress it to maintain equilibrium. So then when somebody stops that pattern of alcohol consumption, that fight or flight network is more unopposed. And that's why when someone's in withdrawal, you see what you see, the anxiety and the shakiness and nausea and vomiting that's really difficult to overcome without treatment or without getting more alcohol to relieve it. And so these are the agents that we currently have, or some of the agents we currently have available to overcome the craving and to a certain extent block sort of alcohol's effects that might lead someone to consume more. Naltrexone is one, and that blocks opioid receptors in that mesolimbic pathway. And so if somebody does drink, then it sort of blocks that positive reinforcing effect of the alcohol. And so if they have one or two, it's less likely for it to turn into 6, 10 or more. It also likely helps with craving. And that's because craving itself may be kind of an opioid rush in that same reward pathway, where if you're seeing someone use or you see substance, get this rush by way of the expectancy, like, boy, it would be great if I was using that right now. And the naltrexone may block that to some extent and make that feel less compelling. Other agents here, gabapentin may also help with the recovery of that GABA, that calming system, where when it's dysfunctional or down-regulated, leaves a person feeling anxious and I can't sleep, and the gabapentin may help. Those uncomfortable things that may trigger stronger desires to drink. Acamprosate similarly may help with that repair process as folks are using it. You've likely also heard of a medication called antabuse or disulfiram. I tend to talk about that less with folks. That's an agent that just makes people really, really sick if they do drink, but it doesn't help a lot with craving. Still an option and something that we'll use from time to time with folks, but it's also a difficult medication to take and educate patients about due to the high frequency of medication interactions, the fact that there are a number of over-the-counter products that contain alcohol, like cold remedies, and even topical things. Applying hand sanitizer can cause that reaction that disulfiram causes, making people really sick. So, so far as addressing alcohol use, I've already mentioned use some of the behavioral approaches with use that falls short of an actual addiction or use disorder. That brief advice or brief intervention may be effective, but for moderate and severe, sort of having more consequences due to that daily use, they probably need more by way of behavioral support, often in addition to that prescription. How long do we continue that prescription in that plan? Clinically individualized, more is probably better. The longer engagement in a recovery plan, the more likely sustained gains are. But any less than 3 months of engagement in a recovery plan is probably unlikely to lead to sustained recovery. The hot button substance, right? Opioids. I know you all are seeing maybe as much impact of alcohol or methamphetamine in your communities, and we know that methamphetamine is becoming more and more an issue. But opioids first, before we get to that. Opioids, I won't belabor the point. These are some of the common substances that fall into that category, including the direct derivatives from the opium poppy, morphine, codeine, heroin, and the synthetics. Methadone, which you may know is an agent used to help folks recovering from an opioid use disorder, and then the synthetic fentanyl I've already made mention of, that is used as a pain treatment, but also is in our illicit opioid supply and causing quite a bit of trouble so far as opioid use disorders. In addiction medicine, one of the other things I find fascinating is some of the history around some of these substances, and heroin has a fairly interesting history so far as that goes. It was initially marketed by Bayer Corporation as a less addictive alternative to morphine for cough suppression, which didn't turn out so well. And it actually was in a number of patent remedies that were getting sold around the country, including Mrs. Winslow's soothing syrup for fussy babies. And so the most common demographic, interestingly, in the United States in the early 1900s for heroin addiction was middle upper class Caucasian women who were using Mrs. Winslow's soothing syrup. And there were a number of other remedies that included cannabinoids and cocaine and the like. But so I'm not telling any of you things you don't know by way of the opioid crisis. It continues to be ongoing. The big shift in it over the last decade is that it's much less attributable to prescription opioids and elicits heroin and fentanyl in the heroin supply being much more a factor since 2010 in this ongoing major upswing in terms of opioid overdoses. So when we think about treating an opioid use disorder or thinking about medication assisted therapy for it, This cycle in terms of someone's opioid use is part of the rationale for it. Early on in use, someone uses opioid and experiences that euphoria, the positively reinforcing sensation that they're looking for. But over time, with repeated use, folks really aren't experiencing that anymore. And they're continuing to use opioid simply to avoid feeling horribly ill and to be able to function during the course of the day. So what the medications that we have available do is they, instead of having someone going through these cycles of ill and well-ish through the day, maintain this stable or more stable, steady state of opioid level that allows someone to function and not be experiencing these periods of impairment due to withdrawal or intoxication. And these are the agents that folks may ask you about and that are out there. Methadone having been around the longest, the relatively more recent FDA approved 20 years ago, buprenorphine, and then naltrexone that I'll talk about briefly. And these are all medications where we think about them being used in a maintained sort of way. Maintenance with buprenorphine or with methadone, we know saves lives. Naltrexone, we don't have those data yet to know for sure whether it's actually life-saving, but methadone and buprenorphine, we do know that. And methadone has been around the longest, been available through federal and state licensed opioid treatment programs since the early 70s. So we have the most data around it. Disadvantage is it is highly regulated, needs to be administered out of these licensed treatment programs. So not widely geographically available, and nearly 2/3 of US counties do not have one of these in it. They provide a number of services in addition to the medication, including counseling and monitoring with urine testing, among other ways, but they're typically not addressing other issues outside of the opioid use disorders. Certainly, there may be some overlap with issues that led to opioid use disorder that a counselor may be addressing, say cocaine use disorder or cannabis, but it's fairly atypical for this programming to be addressing, say, depression or PTSD and childhood trauma and things along those lines. And so that most often requires additional services. Buprenorphine, the other agent I mentioned, is also an opioid that's longer acting. It's safer in ways I'll talk about in just a second, and can be prescribed out of settings that aren't necessarily specialty care. So this can be done out of primary care settings, general psychiatry, and things along those lines. It does require currently some additional training to get a particular license to prescribe the agent, but doesn't require that specialized setting that an opioid treatment program does. Comes in most commonly this sublingual or sort of orally dissolvable film or strip that folks take, though there are also, or tablets that dissolve. There's also a monthly injectable version done primarily out of specialist treatment organizations, but that we'll be expecting to be seeing more of near term. Buprenorphine, I already made mention, we know it does save lives. It does work better than counseling alone. Seems to be similar in terms of how effective it is as methadone in terms of retention in treatment, depending on the study you read and the setting. Primary care actually seems in a number of studies to do better than specialist treatment settings so far as retention in treatment. And this slide just demonstrates why it's less strictly regulated. So buprenorphine, you know, on this y-axis here, you're seeing the opioid effects. So like at lower doses, you might get some pain relief, but as you move up, you're getting the slowing down of breathing and that risk for overdose mortality. And with heroin, fentanyl, and methadone, that risk just keeps going up with higher and higher doses, where there's this ceiling effect with buprenorphine. Once you get to this around 32 milligram dose, If you try going past that, you aren't going to get that greater risk for respiratory suppression and death. And so that's part of why this regulation around buprenorphine is less strict, and there are more settings where it's potentially accessible. Naltrexone is another agent. I made mention of it in helping to treat alcohol use disorder. It can also be used for opioid use disorder. And one advantage is that it doesn't require any special training. It doesn't require any special setting for its administration or supervision. If you have a license to prescribe, you can prescribe naltrexone for opioid use disorder. But getting onto it for patients is really, really difficult because since it's an opioid antagonist, the opposite of an opioid, it goes to those same receptors and it blocks them. So it kicks opioids off those receptors. So if someone's been using heroin regularly daily and they take naltrexone, it's going to put them into immediate and horrible withdrawal. So they need to go through this period of abstinence, at least 7 days before naltrexone can be started. And that's really, really difficult for people. Opioid withdrawal is a really horribly negatively reinforcing state to be in. And to ask people to kind of just deal with that is a fairly Herculean task. It's simply not doable for many. So if it can be done in a controlled environment, say, in a hospital or detox setting, so far as that withdrawal management before the naltrexone is started, that's to the good. Or another setting where it's been getting used with fair frequency is criminal justice involved individuals as they're coming out of confinement, potentially getting them on to naltrexone, since they will have come through their physical dependence and the withdrawal perhaps during their course of their confinement. But again, we don't have mortality data. We don't know if it actually saves lives or not. But another advantage of it is it doesn't cause that physical dependence that opioids do, like methadone and buprenorphine. So if someone immediately dramatically decreases or suddenly stops their use of naltrexone, they don't have that withdrawal syndrome. And it provides blockade of that receptor, again, being an opioid opposite or an opioid antagonist. So it provides some overdose protection. It'd be another advantage. So far as the counseling people get, when they have opioid use disorder and they're on a medication that's indicated for its treatment, the sort of behavioral support that they get probably doesn't matter a lot. The medications have enough impact that if they're, for some folks, that may be sort of all they need, some would argue. Though in terms of coming away from that medication eventually and having sustained remission, we generally recommend some form of counseling, being a part of a plan that has that as a stated goal. But that can be a wide variety of forms. Can be, peer recovery. It can be counseling. Doesn't necessarily have to be part of a specialist treatment agency. So it can take a variety of forms. And I think some healthcare providers have that misconception when they think about, boy, I'd like to help patients with opioid use disorders, but I don't have access to specialist treatment. And I think the guideline tells me I have to have that in order to prescribe. And that's not accurate. If they have access to some sort of behavioral therapeutic intervention, then it's a practice in which they can engage. Other things in which multiple agencies can engage to help guarantee the health of folks who are currently using and help them get to a point where they seek recovery and have the wherewithal to participate in it, are health promotion services and making sure we give the advice and provide resources that they need to maintain health while they are using, or things to be aware of. Wisconsin is fortunate to have fairly wide reach through Vivent Health, the syringe service program, providing counseling around HIV, hepatitis C prevention, as well as overdose prevention and access to naloxone or Narcan. And that really being, the primary model here. We don't yet have formally recognized supervised consumption sites, or what used to be called medically supervised injection sites, but they're There are some fairly early data from one that's unsanctioned. In this article, they don't even tell you what city it's in to maintain its secrecy. But they are having some success there, and over 10,000 injections at this site over 5 years. There have only been 30 overdoses and no fatalities and appropriate interventions in all those cases. This is the naloxone formulations. This is the nasal spray, the one that's most commonly dispensed these days. You may also see these kits that folks need to assemble. And there's this Evzio auto injector that actually talks you through an overdose intervention. So there's a similar formulation for the EpiPen that talks you through the assessment and the actual administration. There's also a number of apps around opioid overdose recognition and intervention. Opie Rescue, I think, is the one that I've found to be most user-friendly in terms of its interface and most strongly based in evidence that I appreciate. So,
hey, Randy.
Yeah.
Oh, cool. Awesome. My audio works. Just wanted to make sure we leave some time for questions.
Yep.
If there are any, unless you had a couple more things you wanted to touch on.
Yep. I will rocket through these last couple and jump to that. I'm sorry. I did not think this was going to take as long as blah, blah, blah.
You're just so excited.
I know. So far as the stimulant use disorders, unfortunately, we don't yet have FDA approved medications for them. There are other medications for other syndromes that have had some impact. These can be prescribed out of primary care, but there may not be a ton of awareness about it. There's some interventions to help folks that are withdrawing from cannabis. There are less things that we know about that help with craving. But that was essentially what I had, and I want to stop there. Sorry for rocketing through that last stuff so quickly, but want to make sure we have time for any questions about anything that I did go through or otherwise when it comes to use disorders and treatment. And while you're thinking about that, let you know for our forum in May, we're going to be going more the prevention angle with the learning community. There's a professor in the School of Education here named Andy Garbosh that's done a lot of work around youth prevention and models such as the family checkup, where I hope you'll all be able to come to that too and hear what he has to say. So any comments or questions folks have? Or
I have a question.
Yeah.
I was interested in, you had said that like the inpatient things are about a month long, right?
Well, not all. I mean, that's fairly typical. Some are shorter, like 7 days, 14 days. Some residential will go out as long as 3 months. So far as what insurances will typically pay for, yes, there are Cadillac versions that people can pay cash on the barrelhead for and ride horseback in Santa Barbara for 9 months and get tons
that
of
sounds awesome. But you had said that your research shows that you need at least 3 months.
Oh, so not necessarily 3 months of residential. The 3 months minimum is more for engagement in some program of recovery, where if you engage in a program of recovery for less than 3 months, be it outpatient, inpatient, peer support, or otherwise, outcomes farther out are indistinguishable for not having done anything. And that's where that 3 months is really coming in. Like if your goal is to be in recovery, remission, longer term, you should anticipate participating in some program of recovery for at least 3 months. And that can be inpatient, a combination of inpatient and outpatient.
That's real awesome. That's really interesting. Thank you, doctor.
Yeah.
I have a question too, Dr. Brown.
Yeah.
Do you know, actually I have two questions. The first one is, what do you know about like the, I can't think of the word, the fake fentanyl, what's it called?
Oh, so like you mean like the counterfeit tablets, or you mean
the word for fake? And I'm having a huge break. Synthetic, that's what it is. Like, do you know anything else about the synthetic fentanyl?
So yeah,
Just
fentanyl,
like-
yeah, so there's all kinds of synthetic opioids that are kind of related to fentanyl. There are dozens of them now. For example, another one that got a lot of press is carfentanil, the elephant tranquilizer, where fentanyl is roughly 400 times as potent as morphine. Carfentanil is 40,000 times as potent as morphine. And there are a number of substances like that that are kind of cousins of fentanyl that are in the supply. Is that what you were asking about?
Yeah, well, my mom just I lost my mom on New Year's Day, and that was one of the things that came up in her that she had overdosed, and it was out in Arizona, and I was just wondering, that was the first I heard of like any synthetic fentanyl. That was what was in her toxicology report. So I was just wondering if there was anything that you I have honestly haven't heard. I mean, I've heard of like synthetic marijuana and stuff like that,
Yeah.
you know, over the years, but this is the first that I've heard of synthetic fentanyl, so I wasn't really sure what it was. I was just curious.
Yeah, and it's
And I had a
out there.
quick question about that periscope thing you mentioned.
Yeah.
I caught like just a pinch of it.
Yeah, and we can get information.
What is the website for?
Yeah, there is. Actually, here, let me stop share, and I can maybe I can put that in the chat quick. The Periscope project, that's one where healthcare providers can call in. They get access to someone with expertise, not just in addiction, but OB-GYN and perinatology, and can get advice
Okay.
about taking care of a patient who's pregnant and struggling with a use disorder. But they also have a number of kind of patient-facing materials too that people can access and get information about resources. Here we go. There. So and there's the link for that.
Nice. Thank you.
And then now that I've opened up the chat, I've gotten to the right view. I see some questions. So do you think that someone on Suboxone should eventually be weaned off in the time frame? And that's a great question. And that again is where we look to that evidence indicating like being on it less than 3 months, probably not. If they're on it for somewhere 3 months to a year, or even longer. I mean, some folks do need it for life, but beyond a year-ish, it really becomes a clinically individualized decision. You know, how is someone doing in terms of their ongoing use of opioids and other substances? How are they doing in terms of other mental health conditions? And are they in appropriate care for that? And are those things stable? What's their environment like? You know, if they're in an area where a lot of use is happening around them, or if it's in their home, we might think less about tapering right away. And the other thing that we need to really balance that carefully with is really close monitoring as someone comes off of Suboxone or off of methadone or anything else, because once someone has been abstinent from those or other opioids for even a fairly brief period of time, their tolerance goes down and their risk for overdose goes way up. And so that's the other thing that care providers will be thinking about is, you know, that abstinent period, overdose risk, and keeping a really close eye on folks so far as it goes. But yeah, a trial at about a year for most folks is probably okay. But again, it depends on all those factors so far as how they're doing.
Dr. Brown, on that, the naloxone, because on the Narcan, I took a training for that.
Oh, great.
You know,
good for you.
But on the naloxone, does that come straight from the doctor's office to prescribe that for a patient or client?
Yeah, great question. Because yeah, those things do sound really familiar, or really similar. Naloxone, naltrexone. Naloxone is the opioid overdose reversal agent. It's really short acting, so that's that urgent, life-saving. I'm near someone who's experiencing an overdose, give it to them now. Now, Trexone, you know, it behaves in the body in a similar way, right? It's blocking those opioid receptors, but it's longer acting. One is a pill that someone takes by mouth every day. Another is an injection that's given once a month. And then naltrexone, the daily pill and the monthly injection are both things that, yes, need to be prescribed by a physician. And in the case of the injection, given in the office.
Okay, thank you.
Dr. Brown, there was a follow-up question about Suboxone. Would it be necessary to be on it for life or for longer extended periods of time, or is it a temporary
yeah, you know, and
treatment option?
Yeah, and that again depends on all those factors so far as how someone is doing. Another thing that may make us wonder if someone's going to need it longer term is how early in life their regular use started. And so if someone started using opioids really regularly during adolescence or young adulthood, when crucial portions of the brain would normally be kind of developing, then that can be a situation where the addiction is more relapsing, remitting, more difficult to break out of. We might think it would be more likely that they'd need lifelong treatment with an agent, and not everyone does. And I think a taper is worth considering in appropriately selected patients with appropriate supervision. But there are some factors like that where we think, boy, you know, long-term use, complicated mental health, really poor recovery environment or challenging recovery environment, they may need to be on it longer term. And yeah, some folks are on these for life, you know, based on a number of those considerations.
Dr. Brown, whatever happened to that, the Antabuse? Do you remember that?
Yeah, you know, and it still gets used sometimes, but you know, those other agents that I alluded to look to be more effective in terms of reducing craving for alcohol and reducing use, and they're more straightforward. You know, if you're a primary care doc in particular, you're interested in helping someone with alcohol use disorders, those are a lot more straightforward to prescribe than Antabuse or disulfiram, because Antabuse or disulfiram, it has a lot of other medication interactions that can cause a problem. Again, there's that issue with Antabuse. If you use alcohol, it makes you sick when you take it. Hand sanitizer does too. Over-the-counter cold remedies that contain alcohol, if you actually swallow your mouthwash, can cause a problem. So it's more complicated to use, and some of those other options are less toxic and tend to work better. You know, there are some programs. The other thing is, you know, when it's been studied, it hasn't worked quite as well. Some of that is because folks don't take it. So we know that, you know, if you're in a primary care practice, you hand somebody a prescription for Antabuse and say, here, take this every day and go forth and recover. It's not really going to work. But supervised dosing can be helpful. And so some specialist programs will do that. They'll actually supervise someone taking it. I've occasionally enlisted the help of a close personal contact or a partner who seems appropriately engaged. So yeah, it's still out there. It's still FDA approved. We just have some things that are less toxic and look to be a little more effective.
Okay.
I have one question. We are at a small tribal facility in rural northern Wisconsin. We are considering starting our own Suboxone treatment program, and we only have 2 family providers. One has their X waiver but has never done anything with it. The other one is our physician medical director, who his statement the other day was, isn't giving them Suboxone just trading one addiction to another. So we're trying to find some really solid trainings to train our family providers to get them up to speed about the evidence and support for these type of treatment modalities. So do you have any good solid recommendations on how to connect them with up-to-date especially physician level ones. I don't want to,
Yeah.
I don't want to send them to trainings that talk about the basics, nuts and bolts that most physicians know of, but the ones that really get to the meat of the core of treatment and the evidence behind it.
So one thing, I'm just trying to get back to one slide. So one thing I'd throw out there is we're doing what we're calling like a substance use disorder management boot camp
Okay.
in May. That's a full day. Megan, is that May 14th? Yes, May 14th. So we should make sure to
May
get
14th.
information on that out to the group. And that's going to be, you know, a day where, yeah, we go into some of that. So they've already done the data waiver training. So they've gotten a lot
One of them has. The physician the physician that made that comment has not. So that was another thought, is should we just have him do the X waiver training? And would that suffice? Would that be, because he's not required to do that now as an MD. So he doesn't need to do that.
Although that hasn't taken effect yet. So yeah, you're alluding. Yeah, so you're alluding to the fact that DHS, yes, earlier this year indicated that they're going to do away with the data waiver requirement to prescribe. That's not effective yet, and we don't know when it will be.
Okay.
But yeah, I think the waiver training, so it's still available. That would be a really good first step. It provides a lot of that education around the rationale, like, why do we do this? You're giving someone an opioid who was using opioids before. Why? That again has to do with that definition between physical dependence versus a use disorder, right? If someone's using Suboxone every day as it's prescribed, they're functioning more highly, they're less likely to die, and they're moving toward recovery. So, you know, and there are a lot of things contained kind of in that training that get at that. The boot camp that we are going to be putting on in May takes a little bit deeper dive, because the data waiver training is the really high level view. This is how buprenorphine works, and this is how you use it. In our boot camp, we do a lot more talking about, okay, I got all that, but how do I really do this in my practice? And we do more by way of case discussions, like some of the stuff that's going to come up when you're monitoring, and, oh man, I got this urine test that's positive for all this stuff. Do I keep prescribing for this person, or do I cut them loose? And
right.
And those kind of things. And then we'll also make sure we get info, or I made mention of our monthly echo, where we get together as a community and just talk about these kinds of issues in practice too, that I think is super helpful. Just hearing about practice in the community, people that have been doing this for a while, and different strategies that they've used to approach some of those issues. As they start prescribing again, there's the call-in line, you know, which is open from 8 a.m. to 5 p.m. during the weekdays. So, and they could call that in advance, you know, if they're scheduling a patient, and they're like, oh, I've got this patient coming up, I'm not sure how that's going to go, and we can have a conversation before that visit to tee it up. And they can call when the patient's there if there's something going on, and
nice,
we can help through that. The other thing that's available online so far as evidence that I was trying to get to here, that SAMHSA, the Substance Abuse and Mental Health Services Administration, it's called PCSS, the Provider Clinical Support System. And they have, so SAMHSA, PCSS, I'll see if I can get the link up here quick. I know I'm running over already, but and that has a lot of access to education also around providing this care. You know, they have a couple of different PCSSs. One's more for pain management and prescribing opioids, and others are more for opioid use disorder management.
Got it. Okay.
And that's a place through SAMHSA PCSS, they can get connected to mentors that can help them, but we'd love to help you all out here too. And you can have a mentor. They can have a mentor a little closer to home
Thank
here in
you.
Wisconsin.
Yeah. Thank you for the training today.
Yeah, absolutely.
Awesome. So any additional questions can be sent my way, just because we are a little bit over time, but thank you everybody for coming. And we did include the registration link for in May, not next month. So May 17th session. And then Liz also included a link for an evaluation, but we will send that out again. So thank you everybody. Enjoy the rest of your afternoon. And if there's any more questions, I'm not sure if Dr. Brown has to go anywhere, but I know he's excited to answer any questions either as well.
It was really great to be here. Great discussion, and hope to see everyone back in May. We'll get the slides to you so you have email for me as well. You know, if questions come up and you want to contact me with any of those.
Great. Thank you everybody.
All right.
And I'll send out this recording as well.
Thanks.